Okay, doctors, we are in our last lecture of the morning. Next lecture is Small Intestines, given by Dr. Mark Singer, who is assistant professor at Rush University. Please welcome Dr. Singer.
Okay, thanks very much. Good afternoon, everybody. Here are my disclosures. Okay, here is a summary of the topics we're going to discuss this morning regarding small intestine. We'll start with small bowel obstruction, probably the most important of these topics. So we'll open with a case scenario. 55-year-old man presents with abdominal pain and vomiting. His CT scan shown on the screen. Which of the following is the most appropriate treatment? Go ahead and use your clickers for your response. Choices are A, observation, B, laparoscopic reduction, C, bowel resection, D, contrast enema, E, double balloon enteroscopy. Okay, a few seconds, get our responses in. C, bowel resection is the correct answer, which most of you answered appropriately. We'll talk more about this, but what you're viewing here is an ileocolic intussusception, and this X-ray represents the target sign. Okay, so common causes of small bowel obstruction. For most of us in practice, postoperative adhesions are going to be what we most commonly encounter, but it's important for the purposes of this type of exam to remind ourselves of some of the less commonly encountered causes of small bowel obstruction. Intussusception, as we just saw in that CT scan, bezoar, not that common, but you should not overlook. Gallstone ileus, Crohn's disease, which we'll talk in some detail about, volvulus, and cancer. And when it comes to cancer, most of us probably are used to treating GI malignancies, colon cancer, pancreas cancer, and the likes. But we should also not overlook non-GI cancers. Ovarian cancer would be one of the typical ones causing small bowel obstruction. Workup, as you know, is imaging to help locate the transition point. A good history to understand the onset of symptoms. Is this an acute problem, more of a chronic problem? How severe are the symptoms? Are patients having some gas and bowel movements, or they have a complete obstruction with no gas or bowel movements and vomiting? As always, we start with x-rays. Although in practice, perhaps everybody gets a CT scan as soon as they hit the emergency room. It's important to remember that x-rays, paying attention to upright abdominal films or chest x-ray is important, as this might obviate a CT scan and allow you to take patients directly to the operating room. Sometimes on the exams you'll see CT scans such as this, and here you see classic hernia, ventral hernia, with incarcerated bowel causing an obstruction. Intussusception, which we saw in the opening case, the ileocolic intussusception presenting with pain, vomiting, and such, and this will give the target sign, or bullseye sign, sometimes referred to on CT scan, and what you're really seeing is the ileum inside of the colon, both of which are usually thickened, as you see here. In adults, this is generally considered to be caused by a pathologic lead point, unlike in children, and so these patients should all be treated with an operation and a resection. Sometimes they'll reduce spontaneously in the process of evaluating the patients. Even if these patients reduce, have a big bowel movement, and feel better, you should still proceed with your workup and probably a resection, because they're at risk of having polyps, cancers, or something abnormal causing this type of intussusception. Closed loop obstruction, sort of a subset of the small bowel obstruction. So these patients will sometimes present with pain, distension, but not necessarily vomiting, because they have perhaps just a short loop that's obstructed. And this happens either because they have multiple lesions, like in the setting of carcinomatosis, or they have a bowel that has twisted, torsion about the mesentery, which will give a short segment of a closed obstruction. So first question to decide really is, does the patient need an operation immediately, or can you employ a non-operative strategy? Of course, all patients are going to undergo the usual resuscitation, fluid and electrolyte replacement, Foley for urine output monitoring, and NG2 for decompression. And then think about whether the patient is eligible for non-operative management. Patients with low-grade obstruction, so those who might be distended or even vomiting but still passing some gas and stool. Patients with Crohn's disease, which will usually be apparent on the CT scan. So if they have inflammatory changes of the small bowel, this might often be managed medically with steroids and such, and we'll talk more about that. Early post-op obstruction in patients who are otherwise stable. So this is a common scenario, of course, trying to differentiate post-op ileus from adhesive obstruction. As we know, in patients who have an obstruction in the early post-op period, they generally do not progress to gangrene perforation, and so usually safe to manage these patients non-operatively, even for extended period of time, even up to 30 days. So although tempting to get the patients recovered and out of the hospital, it's generally safe to leave these patients decompressed, supported with fluids, TPN, et cetera, and not operate on them in the post-op period. Other types of obstruction that are best managed non-operatively, hematoma due to trauma. That's something that, of course, will resolve with time. Or patients with known carcinomatosis, widely metastatic disease. These patients may not resolve, but because of their overall condition, the patient may choose to undergo non-operative management. So if you do take these patients to the operating room, the goal, of course, is to relieve the obstruction. Whether you do this by laparotomy or laparoscopy, for the details of an exam, doesn't really matter too much. This is the kind of thing that depends on your skill set and comfort, but the questions will mostly focus on taking them to the operating room and doing lysis of adhesions or resection of whatever pathology is causing their obstruction. Determining the bowel viability, of course, important. In the picture you see here, this bowel is clearly dead and needs to be resected. But it's not uncommon to have questions about how you can determine whether bowel needs to be resected or not. And so direct observation, looking at the color, observing for peristalsis, using a Doppler to evaluate the blood flow, or old-fashioned Woods lamp and fluorescein to give you sort of a poor man's angiogram to see if there is reasonable flow. Once determining the extent of your resection, then you need to decide about restoration of bowel continuity. In general, you should manage patients very conservatively and be very liberal to give them ostomies. It's always safe to give somebody an ostomy, but it's not necessarily always safe to restore continuity. And also make liberal use of the second look laparotomy. So if you decide to leave somebody not in continuity or do an anastomosis, that's okay, but have a very low threshold to take patients back to the OR. So common scenarios would be you do a bowel resection with an anastomosis, and then 2-3 days post-op, the patient again has white count, hypotension, worsening pain, etc. Proceed to the operating room very liberally. Okay, a few special considerations. So patients who present with a bowel obstruction who have never had surgery, this is always concerning. Some of these, of course, are benign, but some of these are much more significant. Intussusception, as mentioned, be very suspicious of a lead point causing the intussusception in adults. Children, much more common to be a benign situation, but in adults, you worry about polyps, cancers that need to be resected. The obturator hernia, certainly one of the less common hernias, but this is one of the classic hernias that may not have good physical findings, like a typical inguinal hernia, umbilical hernia. You may not be able to identify this on your physical exam, and so these are patients who need imaging and operative repair. We'll talk about that later with the hernia lecture. Gallstone ileus, again, not all that common, but keep it in mind. Bezoar, taking a history of food intake and stuff. And then again, cancers. Patients who have not had surgery and present with small bowel obstruction, you should have a very high degree of suspicion for cancer. Of course, GI cancers, which we're all quite familiar with, colon, pancreas, and all the usuals, but non-GI cancers as well. Ovarian, commonly asked, because that's one that will often present in appropriately aged women with no previous surgery, who present then with carcinomatosis related to ovarian cancer. Patients who have had surgery, of course, think about adhesions, but not just adhesions, internal hernias, and sort of a classic presentation would be patients who have had gastric bypass or Roux-en-Y surgery for ulcer disease or any other indication. Internal hernia, definitely something to keep in mind on these patients, and these should be fixed operatively. All right, we'll talk a bit about small intestine Crohn's disease. Here's a case to review. The initial management of newly diagnosed terminal ileal Crohn's disease includes, go ahead and start entering your responses, small bowel resection, diagnostic laparoscopy, infliximab, 5-ASA compounds, azathioprine. Okay, a few more seconds. Okay, great. Almost everybody got the correct answer, 5-ASA compounds. Again, this is a patient with newly diagnosed Crohn's disease. Of course, it depends on the severity and the presentation, but in general, 5-ASA compounds are going to be a good place to start in managing small bowel Crohn's disease. Most patients, somewhere around 3/4 of patients, will have a reasonable initial response to ASA drugs like sulfasalazine, mesalamine. In the long term, these drugs are problematic as compliance is very poor. The frequent dosing and common side effects will force many patients to stop the drugs themselves. Steroids, we're all familiar with. We know these are great drugs in the short term, and these have a very good response rate, 80% in the short term, and this is great to treat acute inflammation. So patients who present with a flare, whether it's their first presentation or a recurrent presentation, come with pain, inflammation in the small bowel, maybe obstruction, maybe not. IV steroids usually do a reasonably good job of decreasing their inflammation and getting them through the acute process. But we also know that these drugs in the long term are wrought with complications, and there's a very long list of complications that you should be familiar with, including weight gain, skin and hair changes, ocular complications, fluid and electrolytes, adrenal suppression, and all that. So patients should be tapered as quickly as possible. And this comes up commonly. The specifics of the complications are usually not part of the sort of question, but it's always a question about transitioning patients off of acute steroids onto other types of medical therapy. One such therapy would be anti-TNF agents, whether you're using IV agents like infliximab, the oldest and most common, or newer drugs like adalimumab, Humira, or the even newer drugs, which is delivered subcutaneously. These drugs have a very good response rate, 70% or better, and currently are favored by most gastroenterologists for long-term management, so weaning patients off steroids onto the anti-TNF drugs, the biologic drugs. These drugs are very helpful, also have several issues. They're very expensive. They require kind of indefinite dosing once patients are started on these. Gastroenterologists hate to take them off because patients can become immune to them, especially with infliximab. This is a mouse anti-TNF antibody, and if patients are stopped, they basically develop immunity or an antibody to the drug itself. So once patients are started, the GI doctors never want to stop them, because if they want to resume therapy, it just doesn't work because they become immune. So this should be taken seriously when starting patients on it. Antibiotics do have some role in treating Crohn's disease, mostly in the acute phase. It's not entirely clear why antibiotics should help settle Crohn's, whether there's a direct effect on their bowel and inflammatory process, or somehow changing the flora in their bowel, but usually drugs like Cipro or Levaquin and Flagyl are offered to these patients and usually has a good response in the short term. Now, when patients present acutely, understanding whether they have a phlegmon versus an abscess is certainly critical to their management. A phlegmon can be managed with steroids, antibiotics, Remicade, all that stuff, but if patients have an abscess, of course, you definitely do not want to immunosuppress them. So that comes up commonly on questions. Abscess should be drained, whether that's percutaneously by radiology or even operative drainage. That's going to be the first step with antibiotics, most likely. But all abscesses must be drained before starting any immunosuppressive agents such as steroids or biologic drugs. Okay, so another IBD case here. 21-year-old man with Crohn's disease and multiple previous small bowel resections presents with small bowel obstruction. On laparotomy, he's found to have a total of 170 centimeters of small bowel and a tight stricture in the jejunum. Most appropriate surgical option is small bowel resection with anastomosis, strictureplasty, loop ileostomy, intestinal bypass, small bowel resection with diverting ileostomy. Okay, a few seconds. Great, almost everybody, strictureplasty. So a common theme is that Crohn's patients sometimes require multiple operations. It's unpredictable what patients will require one operation in their lifetime or what patients are going to require 10 or 20 operations. It's always important when making treatment decisions to consider what if this patient requires multiple operations, and you have to employ bowel-preserving strategies. So strictureplasty is going to be a common bowel-preserving strategy. This patient is already on the borderline of short bowel syndrome. He has only 170 centimeters, and so for sure you would like to avoid further resection if possible. Now with that in mind, because these patients often require multiple operations, and considering the fact that Crohn's disease is essentially a non-curable disease, we really try and reserve surgery to treat the complications. So thinking about what are the indications for surgery: medically refractory disease, failure to wean off steroids. Those two are sort of one and the same, and that's a common question. Patients unable to get off steroids, even if they're doing well, even if they have a normal bowel habit and stable weight and feel great and all that kind of stuff, that's a good indication to operate, because as we discussed earlier, steroids are going to be problematic in the long term. Obstruction, for sure, is a good indication to operate. Fistulizing disease, so this comes in a variety of formats. Enterocutaneous fistulas almost always are going to require an operation, but even internal fistulas like enterocolic fistulas. Although patients can manage these sometimes, they often will cause chronic diarrhea that becomes unmanageable if they have, say, a proximal small bowel to sigmoid fistula, that type of thing. They're going to get massive diarrhea. Definitely fistulas to the bladder, vagina, occasionally uterus. These are going to cause symptoms that are usually not well managed medically and are good indications for an operation. Patients who present with a phlegmon, sometimes it's not always clear whether they need an operation or not. If they're not overtly septic or obstructed, these can be managed with anti-inflammatories and antibiotics. But sometimes the phlegmon will cause secondary obstruction. So commonly a retroperitoneal phlegmon might be causing a ureteral obstruction, which may be managed non-operatively with stenting and that, but sometimes is a good indication to operate and clean it out. And then in children and adolescents, growth retardation for sure can be one of the factors driving towards operation. So when performing small bowel resection in the setting of Crohn's disease, it's mandatory to assess the entire small bowel from beginning to end. Although patients most commonly will present with ileocolic disease, you would hate to do a resection and find yourself back in the OR a short time later because you did not identify additional strictures just proximal to your resection. So a full assessment of the small bowel mandatory. Resect only the grossly affected bowel. Again, you don't know how many resections this patient is going to require in his lifetime, and so you should resect only what appears to be abnormal. There was a time where people were considering biopsies and frozen sections and all this, looking for inflammatory changes at the margins, but that's not really a helpful technique. So resecting to bowel that looks relatively soft and normal, does not have a ton of creeping fat around it and seems reasonable, is the best strategy. There was a time when much was made about whether these should be stapled or hand-sewn anastomoses, and basically these are equivalent. You should feel comfortable to do what your preferred technique is. And then always keep in mind short bowel syndrome. Even on your first operation, measure their bowel because you need to sometimes follow that progression. Whether it's their first or 10th operation, always measure how much you're taking out and, just as importantly, how much you're leaving behind, because this may guide your decision-making on subsequent operations. Okay, so we talked about strictureplasty as one of the common techniques to avoid massive bowel resections. So strictureplasty is a good choice in patients who have diffuse involvement of the small bowel. So a first-timer who has ileocolic disease, they're going to do well with an ileocecal resection, no doubt about that. But in somebody who comes with multiple strictures or multiple sites of fibrosis and creeping fat throughout their bowel, you want to be very cautious about any resection you do. Patients who have prior bowel resections more than 100 centimeters or multiple resections totaling more than 100 centimeters, you should, again, start worrying about short bowel and do strictureplasties. Patients who have an obstructing fibrotic stricture without associated sepsis. So patients who have small perforations and phlegmons, you have to be very cautious about doing a strictureplasty because it's unlikely to heal. So that brings us to contraindications. So malnourished patients, which unfortunately many of these are, bear in mind a strictureplasty is a suture line, just like an anastomosis. So for all the reasons you don't want to do an anastomosis, don't do a strictureplasty either. Severely malnourished patients, perforations, local sepsis, don't do a strictureplasty at the site of a fistula. So if you take down an, say, iliosigmoid fistula, don't do a strictureplasty right there. Strictures that are right before a resection, just extend your resection to include it. Multiple strictures in a short segment, those will do better with a resection of the entire segment. And any concern at all for malignancy. So bear in mind, if a patient has a stricture, that tells you it's been chronically inflamed, and that sets them up for malignancy at that site. Small bowel cancer, of course, a rare cancer, but in the setting of Crohn's disease, it's much more common, and so you have to really evaluate how long have they had that stricture. Do you have any concern at all that there could be a cancer in it? When you open it, when you feel it, it's okay to open the bowel and examine it, even take a biopsy if you're worried about it, but do not do a strictureplasty if you have any concern whatsoever for malignancy at that site. Here are the two most common techniques to do strictureplasty. The first one, really just dividing the stricture and closing it in a transverse fashion, and this can be done in 1 layer, 2 layers, whatever you're comfortable with. None of that has ever really been shown to make a difference. And then for longer strictures, the Finney type, really just folding the stricture onto itself and doing basically a side-to-side anastomosis, as you see here. And both of these work well. Okay, moving on to some other causes of small bowel obstruction or related issues. So short bowel syndrome, as we mentioned with Crohn's disease, this can occur not just from Crohn's disease, but from bowel resection of any cause, trauma, other malignancies, vascular injuries, whatever. Minimum of 75 centimeters of small bowel is needed. This number of about 75 or 100 centimeters is the bare minimum. And then it, of course, depends on which part of the bowel and what you have left. So if somebody has an intact pylorus, an ileocecal valve, they'll do better. So you can get away with a little bit less bowel if they have an intact ileocecal valve. If they have no colon at all, then you're going to need more because the transit time through the bowel is going to be greater, and so absorption will be worse. So in that scenario, probably somewhere in the range of 150. You're not going to likely be questioned on that, like 150 versus 160 versus 125. It usually will be apparent that the patient is short, and so you're going to make your decisions based on that, doing a resection versus not. These patients have chronic diarrhea, of course, and they have electrolyte abnormalities, and it's important to know they have non-bloody diarrhea. Their bowel, presumably, is okay, it's just they have very rapid transit time. If it's bloody, you have to worry something else is happening, infection, inflammatory bowel, etc. These patients usually are often on or permanently on TPN, and volume management is always an issue. Adding H2 blockers or PPIs is helpful because that will reduce the volume of secretion and help with fluid losses. Okay, radiation enteritis. So radiation enteritis really takes two forms. Initially, there's an acute injury, which alters the absorptive and resorptive functions. So patients will have crampy abdominal pain and diarrhea. And this is what occurs acutely, like while patients are receiving radiation therapy or shortly after. This then progresses to more of a chronic issue, and this is really a vascular injury in the chronic phase. They get a progressive endarteritis. And because it's a vascular problem, over time they will develop fibrosis. So this is why these patients go on to get strictures, because they have chronic ischemia at the microvascular level. And as that heals, they're left with strictures. These patients have some degree of malabsorption. Sometimes they can be managed by simply altering their diet, putting them on an elemental diet, sort of a pre-digested diet, but sometimes not. Resection of strictures is sometimes required if the patients are having obstructive symptoms. Bypass is something good to remember in operating on these patients. So a classic example would be a woman who had radiation for cervical cancer and has a loop of bowel densely adherent deep in the pelvis that you can't really remove or dissect out of the pelvis. And so doing a bypass of the segment is usually a good option. The rest of their bowel presumably should be normal, and so bypassing that segment of strictured bowel should help them. All right, other issues in the small bowel. Meckel's diverticulum. So Meckel's diverticulum for most patients is going to be an asymptomatic finding. Occasionally, these patients, though, do present with bleeding. As you remember, this is related to the ectopic gastric mucosa that's within the Meckel's diverticulum, which will cause bleeding of the small bowel, not necessarily within the diverticulum, but on the wall opposite of it. Can also serve as a lead point for an intussusception or even a volvulus. This is often an incidental finding when doing a laparotomy for other reasons, and it should not be resected or treated if asymptomatic and found incidentally. So if doing a colectomy or cholecystectomy or whatever, don't take these out if the patients don't have symptoms. Now, if they're bleeding, one way to investigate the bleeding would be with the Meckel scan, the nuclear medicine scan. It's a technetium-99 scan, which will bind to the ectopic gastric mucosa and help you identify that. Sometimes angiography can be helpful to identify the site of bleeding. Usually these patients, if they're bleeding, are going to undergo endoscopy first, upper and lower, as with most patients with bleeding. But those, of course, will be non-diagnostic, as this is going to be in the small bowel, so usually these patients are going to get the nuclear scan several steps down the road. Now, if it is bleeding or causing an intussusception or volvulus, management should include resection. It should be a short small bowel resection of the diverticulum. Occasionally, for other types of diverticulectomy would be a reasonable option, but for this, you should do a resection, not just a diverticulectomy, because again, the mucosa will cause bleeding not in the tick, but in the wall opposite of it, so you want to take all of that out. All right, mesenteric ischemia. So this comes in a couple of varieties. Arterial occlusion, which can be related to an embolic phenomena. So commonly this will be in the patient who has atrial fibrillation, is at risk of forming a thrombus in their left heart, and flips an embolus into the superior mesenteric artery. Also, thrombotic disease in the superior mesenteric artery. So these are going to typically be in older patients with vascular disease, smoking history, high cholesterol, the usual risk factors, who then has progressive disease of the SMA until the point of occlusion. These questions are almost always going to be about the SMA. Vascular disease of the IMA is usually not significant. Many patients, as you know, will have an occluded IMA, and rarely is this going to present as a symptomatic problem. Non-occlusive ischemia, not uncommon to have these types of questions. These are going to be patients who have low flow states. These are patients in the ICU for medical issues, pneumonia, cardiac things, stuff like that. They're somewhat hypotensive or in heart failure, and then they have low flow, and they have basically demand-related ischemia because of that. These patients should be treated initially supportively, so treat their blood pressure, treat their volume status, support their cardiac function medically, and most of these patients will get better. Now, on the opposite side, venous occlusion, so mesenteric venous thrombosis is an entity that sometimes presents as a surgical problem. This happens in patients who are hypercoagulable for whatever reason, sometimes in the postoperative state, commonly in patients with IBD. Those patients are known to be hypercoagulable. This is a very common occurrence in patients with, say, ulcerative colitis undergoing ileoanal pouch operations. That's one in particular that has a very high incidence of mesenteric venous thrombosis. Now, most times this can be managed medically with anticoagulation, but occasionally the congestion of the bowel will be so severe that they do require resection of the bowel, but that would, again, be a very unusual state. Sorry, backing up for a minute. Now, for patients with arterial occlusion, most of these patients can be managed initially medically with bowel rest, fluid support, and broad-spectrum antibiotics. The majority of patients will recover from that, but depending on their clinical state, occasionally you have to operate on them urgently. So the classic presentation of an embolus to the SMA, which you see here, the anatomy. Unlike in oral board formats, you're not likely to have to describe the elements of exposure of the SMA at the base of the transverse colonic mesentery, but be familiar with the fact that this is the place you do want to open the SMA so that you can perform embolectomy or thrombectomy. And so that might be sort of the answer to management, not so much the technical details of how to do that. All right, moving on. Postoperative or paralytic ileus. So ileus is something that everybody is certainly familiar with if you do any kind of either abdominal or non-abdominal surgery. Usually in the case scenarios you'll be presented with, it's not going to be a complicated situation of a very complicated intraoperative. It's going to be something straightforward like patients with appendicitis or cholecystitis who then go on to have vomiting, bloating, and all that. So it's not, it's usually a straightforward situation. These questions are not usually tricky where you're really trying to decide, do they have an ileus versus obstruction versus ischemia, that kind of thing. Don't forget that ileus occurs commonly in patients with medical disease, typically pancreatitis, inflammation of any sort inside the abdomen will cause ileus. Sepsis, for sure, is known to cause ileus. Uremia, really any severe medical issue can be associated with ileus. Abdominal or pelvic abscess, and this sometimes occurs in the post-op setting, like after, say, a colon resection with an anastomotic leak, or pelvic abscess related to a tubo-ovarian abscess or some other cause, not necessarily a post-op problem or an anastomotic problem. It's important to differentiate the cause of the ileus and contributing factors. So think about things like bleeding, retroperitoneal hemorrhage, in patients who are anticoagulated or patients who had a large retroperitoneal exposure. They often have a fair amount of blood that can accumulate, and this will contribute to their ileus. Patients' medications, anticholinergics and antihistamines for sure contribute, and then, of course, opiates. Now, all the post-op patients are on narcotics to some degree, and even a small amount are well known to contribute to their ileus. So minimizing narcotics is one of the mainstays of management. Supporting electrolyte abnormalities, specifically thinking about hypokalemia and hypomagnesemia. This is often part of the management, replacing these. And then basically supportive measures, NG decompression in patients who are vomiting or very bloated and nauseous, and bowel rest, supporting their fluid balance, and basically waiting until their ileus resolves. Okay, pneumatosis. Sometimes you may see a question about that. So pneumatosis intestinalis, as you know, is gas dissecting into the wall of the bowel from either the luminal surface or through the serosal surface. Sometimes this will be associated with abdominal catastrophes like intestinal ischemia. Dead bowel will sometimes be apparent by pneumatosis on their imaging. Sometimes infections, sometimes they'll relate it to things like endoscopic interventions. Imagine somebody having a colonoscopy with significant air or CO2 and they have a procedure like polypectomy that can get into the wall of the bowel, and if you're doing imaging shortly after, that might be apparent. Also sometimes associated with dysmotility. Diagnosis made by X-ray, and you'll see the classic finding of bubbles in the wall of the bowel. CT scan can help you define the etiology. And the treatment is based on the diagnosis and really trying to understand if they're having an abdominal catastrophe, but the truth is sometimes this is an entirely benign finding. So in patients who are otherwise fine, it's okay to manage these patients expectantly. Sometimes this is a completely incidental finding. But it's sort of high risk because they're either fine or they have a big loop of dead bowel. And so you really want to be sure that they're fine and otherwise hemodynamically stable, not appearing septic, if you're just going to watch these patients and have a very low threshold to take them to the operating room should their clinical condition change. All right, a few odd things here. So enteric infections, sometimes when patients are presenting with diarrhea, it's not always going to be ulcerative colitis or Crohn's or the usual things. Think about infectious diarrhea. And here you see the usual culprits, Shigella, Salmonella, E. coli. Of course, treatment with antibiotics, not colectomies. Blind loop syndrome, this type of thing still comes up from time to time. Basically, intestinal overgrowth. Patients will have bloating, crampy pain, diarrhea, sometimes B12 deficiency. This can be evaluated by breath test because of the overgrowth of the bacteria, which will then metabolize carbohydrates that the patients are eating. This can be evaluated by a simple breath test. This commonly will be seen in patients who have had, say, ulcer operations, as you see here in the slide, and then they get bacterial overgrowth in the loop that is not in the flow of their intestinal contents. This can be treated either by antibiotics or, if refractory to that, by converting to a Roux-en-Y anatomy. Okay, carcinoids. So let's look at a case here. Most appropriate treatment for a 0.7 centimeter duodenal carcinoid is segmental resection, Whipple procedure, endoscopic resection, somatostatin analog therapy, or chemotherapy. Okay, 5 more seconds. Okay, great. So most people answered C, endoscopic resection. So for a small, and definitely less than 1 centimeter is considered small, endoscopic resection would be the best choice. So neuroendocrine tumors, to remind ourselves, these are tumors that originate from the crypts of Lieberkühn, the enterochromaffin cells. These are often not seen on endoscopies because they're growing in the wall of the bowel, not on the mucosal surface like with a typical adenocarcinoma. These often are going to be asymptomatic lesions, but as they grow in size can definitely cause obstructive symptoms. Because they can be metabolically active, they can cause diarrhea, weight loss. They can sometimes cause ischemia if they're invading into the mesentery, and they can bleed. As they grow in the wall of the bowel, they basically erode the mucosa from underneath, from within the wall, and this can cause bleeding into the GI tract. Many of these are going to be discovered only during laparotomy for other reasons, and sometimes if they're small, will require an operation to locate them. They can be evaluated preoperatively with biochemical markers, 24-hour urine collection for 5-HIAA. This is one of the ones that you should definitely make a note of. This is commonly asked, as is chromogranin A in the blood. And this can be helpful in the postoperative state, evaluating for recurrence of tumor. So in the initial workup, the 24-hour urine for 5-HIAA, and then after resection, follow patients with chromogranin A looking for recurrences. Imaging, of course, CT and MRI, kind of the usual things, but also the Octrio scan, which is basically a nuclear medicine scan like you see here, can sometimes be helpful with a nuclear tag antibody. And then because we're talking about the small bowel, evaluation of the small bowel by double balloon endoscopy, capsule endoscopy can definitely be helpful in identifying lesions that are not accessible by conventional EGD or colonoscopy. So treating these lesions in the duodenum, as we saw in that case, small lesions less than 1 centimeter are most often amenable to endoscopic removal. Large lesions, so more than 2 centimeters, should undergo radical resection, even if that means a Whipple procedure. And then between 1 and 2 can sometimes be treated by transduodenal resection, so basically a duodenotomy with local resection and closure versus radical resection. you're not likely to have to make a difficult decision in one of these. It's usually fairly obvious. It's either a small lesion or a big lesion. But don't be afraid to offer patients radical resection up to and including a Whipple procedure for a larger lesion. Now in the jejunum and ileum, resection is really the only option. These are not easily reached by endoscopy, and because it's easy to resect these, that's going to generally be the best treatment. But the one thing you don't want to do is miss additional lesions. So somewhere around a third of these patients will have additional lesions. So it's fine and easy to do a quick jejunal resection, but make sure you do a very thorough examination of the entire bowel, whether that's by palpation, intraoperative endoscopy, transillumination, whatever. Use all the tricks to look for synchronous lesions. And then the other place these will be found are in the appendix. And we'll talk more about that in the appendix and colon lecture. But again, small lesions do well with appendectomy. Larger lesions, more than 2 centimeters, right colectomy. Okay, carcinoid syndrome, often a favorite on exams. So which of the following is a common sequela of carcinoid syndrome? Weight gain, heart disease, brittle nails, muscle weakness, constipation. Okay. Good. Almost everybody answered correctly. Heart disease. Heart disease, and we'll talk about that. So carcinoid syndrome occurs in maybe 20 to 30% of patients with small bowel carcinoids, usually in the setting of liver metastases. These tumors are secreting vasoactive peptides, but are mostly metabolized in the liver. So it's really usually in the setting of liver mets that you're going to see the carcinoid syndrome. Patients who have carcinoid syndrome, as we know, will have flushing. They'll have rapid onset of secretory diarrhea, heart palpitations, bronchoconstriction, and heart disease, as in the opening case, because these patients have an infiltrative cardiomyopathy, and that can be common in up to 75% of patients who have long-standing disease, and this is one of the causes of death related to heart failure. So patients who do have metastatic disease to the liver should be evaluated for resection if they have a low burden of disease and it's amenable to resection. Non-resection options include ablation, like with radiofrequency, embolization, and some patients may be eligible for liver transplantation. Tumor debulking can be performed primarily to control symptoms, but of course is not going to be curative. These patients often can do well for a long period of time with non-surgical management, even if not curative. Sometimes this disease can be somewhat indolent, and patients can live for many years by simply controlling the burden of disease in their liver. All right, let's talk about some polyposis syndromes. So here's another case. 25-year-old woman presenting with abdominal distension, nausea, and vomiting. On physical exam, she's noted to have spots on her lips, as you see here. The most appropriate initial therapeutic option is ciliotomy, laparoscopy, double balloon enteroscopy, colonoscopy, or chemotherapy. Okay. Okay, so the audience a bit divided on this. Double balloon enteroscopy was the answer we were looking for here, although more people opted for colonoscopy. Okay, we'll talk about that. So this is a patient with Peutz-Jeghers syndrome. The mucocutaneous spots on her lips are sort of the classic finding. You don't see this very often, but when you do, it's fairly obvious, as you see in this picture. So this is a polyposis syndrome of GI hamartomas, also what you see in the endoscopic picture here on the slide. These patients can have small number or very large number of hamartomas, and most commonly in the small bowel, and that's why enteroscopy was the answer for that. I would say colonoscopy certainly is part of the management of this syndrome, and so not entirely wrong. Now, although these are hamartomas, these patients do have an increased risk for cancer, and that's not exactly clear. These are not adenomas, and we'll get to the adenoma syndromes. Those patients obviously have an increased risk of cancer. They all get cancer, but for whatever reason, even though these are hamartomas, these patients definitely have an increased risk of cancer. Indications for operation, certainly symptomatic disease, so large polyps causing obstruction, that type of thing should come out. Asymptomatic polyps larger than 1.5 centimeters that are not amenable to endoscopic management should be removed, because like all polyps, they grow in time, and so if they're getting to that size, they're going to become a problem at some point. Mostly these should be removed endoscopically. And any polyps that are accessible by standard EGD or by double balloon should be removed. Operative strategy, as mentioned before, any of these patients who have small bowel polyps, carcinoids, whatever, you have to aggressively search out the rest of the small bowel looking for synchronous lesions. Use palpation, transillumination of the bowel, intraoperative endoscopy, to really be as thorough as possible to find additional lesions, and then as much as you can remove all the polyps, whether endoscopically or with enterotomy or small bowel resection. Okay, more on polyposis. A 22-year-old woman is found to have multiple adenomatous polyps in her duodenum. Most likely diagnosis for her is hereditary non-polyposis colon cancer syndrome, juvenile polyposis, familial adenomatous polyposis, FAP, Peutz-Jeghers, or Cowden syndrome. Okay, so this, a young woman with multiple adenomas in her duodenum. Good. So she has familial adenomatous polyposis. So the question is telling us these are adenomas, which should clue us in to the fact that she has FAP. We'll talk more about that. We oftentimes think about FAP as a colonic disease, which we'll definitely discuss. But in patients with FAP who have had a colectomy, the next most common cause of death is duodenal cancers. So certainly very much a small bowel disease as well. Small intestine cancer. Small intestinal cancer is a rare cancer for sure, but when it does occur, it's going to be most commonly in the duodenum. Jejunum can be involved in younger patients, but most of the time when you see small bowel cancer, it's going to be associated with one of the risk factors, such as Crohn's disease, as mentioned before. Like any chronically inflamed tissue bed, there's an increased risk of cancer. Peutz-Jeghers syndrome, although a syndrome of hamartomatous polyps, these people still get more cancers. FAP, these are patients with hundreds of polyps in the colon, but still frequent polyps in the small bowel. And as these are adenomas, it's not surprising that some of them will turn to cancer. HNPCC, this one maybe not as obvious. This is a non-polyposis syndrome, but they're definitely at increased risk of small bowel cancer. And then celiac disease, which we know is associated with gluten, but this also has an increased incidence of small bowel cancer. So how do these patients present? As you would think, pain, obstructive symptoms, biliary obstructive symptoms, especially for the duodenal malignancies. Unfortunately, more than half of these patients are going to present with advanced disease, either locally unresectable disease or metastatic disease, because their symptoms tend to present late in the course. Diagnosis is going to be the usual stuff, CT, endoscopy to start, and then because we're talking about the small bowel, standard endoscopy may not be adequate, which means we need to use capsule endoscopy or double balloon endoscopy or old-fashioned contrast studies. Surgical treatment, so duodenal cancers treated with Whipple procedure, distal tumors treated with ileocecectomy, and oftentimes the best you can do is palliate these patients with resections or bypasses to relieve obstructions. Okay, other types of small bowel tumors. Small bowel gist tumors. Small bowel gist tumors can A, be excised in piecemeal fashion. B, should be biopsied prior to treatment. C, do not respond to imatinib, which is Gleevec. D, most occur in patients younger than 50 years old. Or E, most likely to be found in the proximal small bowel. Okay, so small bowel gist tumors, good. Most people, E, most likely to be found in the proximal small bowel. So gist tumors, as in that case, usually more proximal in the jejunum or in the duodenum. These also originate within the bowel wall. They're not mucosal lesions. Usually these are going to be in older patients. The c-KIT mutation is common, somewhere around 90%, which is important because, as was alluded to in that case, treatment with Gleevec can be helpful. Gleevec is only active or an effective treatment if they have the c-KIT mutation, but the large majority of these patients do. They usually present with obstructive symptoms. Many of them will be asymptomatic, having EGDs for the usual reasons of reflux and whatever. And sometimes the non-mucosal lesions will be identified in the wall of the stomach or duodenum. Workup is imaging, CT scan. Chest CT is controversial as lung metastases are rare but do occasionally occur. Endoscopy, of course. Now, they should not be biopsied. These tumors should just be resected. However, if you're going to treat the patient preoperatively with Gleevec, then a biopsy would be indicated to make sure, number one, you have the right diagnosis, and also to evaluate perhaps the c-KIT mutation status. But in general, most of these patients should just undergo a resection. Treatment is segmental resection. Basically just remove the tumor, whether that means a partial gastrectomy or a small bowel resection. Locally advanced tumors can be treated with neoadjuvant therapy, as mentioned with Gleevec. These tumors often have a very dramatic response. You can really downsize these tumors. And then postoperative Gleevec is the usual route of treatment. So undergo resection and then postoperative Gleevec in the c-KIT mutated patients. And the treatment with Gleevec is a prolonged course of therapy, years of therapy. All right, again, another case, 55-year-old man with long-standing celiac disease. He is at most increased risk for A, leiomyoma, B, lipoma, C, lymphoma, D, carcinoid, or E, adenocarcinoma. Okay, so patient with celiac disease is at risk of lymphoma. So a few things about small intestinal lymphoma. So mostly these are going to be B-cell lymphomas. Lymphoma is going to be the most common primary malignancy of the small bowel mesentery. It's not exactly clear, but celiac disease, which is not something we generally consider a surgical disease, seems to have a higher incidence of small bowel lymphoma. So important to take that history when evaluating patients with symptoms. Patients often present in a nonspecific manner. These are not generally going to obstruct patients right away, but they'll have pain, systemic symptoms, weight loss, that kind of stuff. On imaging, usually though, you can identify a large homogeneous mass. Biopsy for these lesions is necessary, unlike GIST, which we mentioned just a few moments ago. These lesions do need to be biopsied so that appropriate chemotherapy can be implemented. Surgical resection does improve prognosis, so it is often part of the overall management plan, but chemotherapy is usually the first step, and if there's an incomplete response, then resection. Okay, so that brings us to the end of the small bowel section. I do think we have time for some questions if we have any from the audience. Yes, sir. Okay, so So first, what do you do with somebody who has a CT scan for whatever reason and is found to have an ileocolic intussusception that you perhaps weren't expecting? And two, why did that patient require resection? So that patient presented with pain, so they're having symptoms. So that's one thing that's going to tip you towards doing an operation, is that they're having obstructive symptoms, pain, whatever drove them to present. Two, again, in adults, there's a high incidence of a pathologic lead point, so you have to be concerned about a polyp or a tumor or a metastatic deposit or something causing this. So if patients are having completely unrelated issues, say kidney stones or whatever, and you see an intussusception, you don't necessarily have to operate on those patients, but you do have to evaluate them. Colonoscopy, repeat CT scan, capsule endoscopy. So not everybody who has an asymptomatic intussusception needs to go right to the OR, but they need a full workup. But if a patient presents with intussusception or symptoms related to intussusception, they should go to the OR. Other questions? All right, very good. So